is Dr. Sunil Kumar Basu Memorial Oration. Uh, to chair this session is in memory of Dr. Sunil Kumar Basu, who was an eminent ophthalmologist of West Bengal, and he had a keen interest in eye diseases and diabetes, and was associated with various social and public institutions in connection with social work and charity run by such institutions. To chair the session, I would like to invite Professor Shubhankar Chaudhary sir and Professor Salil Pal sir. Over to you, sir.
Yes, Professor Khan, would you like to start off?
Yes, Shubhankar, please start.
Sorry, I'll start.
Oh, you start, introduce the topic.
I think that it's superfluous of me to introduce the topic. We have a great orator,
Yes.
Professor Anil Bhansali, and we'll learn about it. And I'm sure the way I've seen the scientific program has been designed, maybe we'll also try to look at what's going to happen in future with the usage of insulin. And maybe Professor Bhansali will also include that in his oration. I think it's over to you to introduce the orator.
Thank you, Shubhankar. Professor Anil Bhansali, in fact, needs no introduction in this platform. He was HOD and professor in the Department of Endocrinology, PGI, MER, Chandigarh, and at present working as professor in this department. He has numerous presentations in national and international journals. He was past president ESI India, received BCI award, and excellent orator himself. Professor Bhansali, you may start your presentation.
I would like to add that it's really our great pleasure, and I'm really thankful to our great friend Anil for having accepted to come for this oration, not physically. Hopefully, we'll meet sooner rather than later physically, and less of virtual meetings, hopefully, in the near future. So, over to you, Anil.
Thank you, Shubhankar. Thank you, Salil, and thank you for your.
So we can you can tell us how far we will go ahead before you pick up.
Yes.
So Shambhapitra, please.
We should go ahead now.
Yes.
Yeah.
Yes.
Just the previous slide. Previous slide, yeah. Yeah. Thank you, Shubhankar. Thank you for inviting me for this prestigious Sunil Kumar Basu oration. So I'll be talking about what we have done in last 100 years and what we are going to have in future with insulin. So journey of insulin, I think, can be conveniently divided into the pre-Banting era, the Banting era, and the post-Banting era. Next, please. Next, please. Yes. So it is surprising that even in a pre-Banting era, many investigators and scientists, they were working on discovery of insulin. And you can see that even in 1889, say almost around 40 years earlier, the Minovsky and Mering, they first demonstrated that the fatal diabetes developed following total pancreatectomy in dog. Same model was used by Banting and West, so they had some idea about that. In 1893, the Hagen demonstrated that the complete removal of the pancreas was necessary for diabetes to develop. So they could identify that they could recognize that an organ like pancreas is responsible for the diabetes. So diseased pancreas is responsible for the diabetes. Then in 1901, the OPE confirmed that the islets of Langerhans could be the source of insulin. So even that knowledge was there. In 1907, the Zurich developed the pancreatic extract even, and that he termed as an acometor, and which was also used in animal models. However, no human trial was done. And in 1920, the Polescu, he was a Romanian scientists, in fact, they made an extract from the pancreas that reduced the blood glucose of dogs. However, no human studies were done at that time. But the Polesco may have been the first to discover insulin about 10 years earlier than the Banting test. So this was the so many people, so many investigators, in fact, were working for a discovery of insulin. They had a concept. They could localize the disease is confined because of disease pancreas. Most of the experiments were performed even at that time in the dog, and they could identify that the pancreas is culprit or islets of even the Langer has in fact by that time localized that. So the islets were considered responsible for the occurrence of the diabetes. Next, please. Yes. So Banting's era starts somewhere in October 1920. And this is one of the monograph from the Banting's diary, and which shows that they said even Banting was an orthopedician, and he just got interested in research after the First World War. And in that period, he just went to Meteor and asked for some laboratory help. So he just provided one old storehouse and some 10 dogs to him that you go and experiment. But it was not an easy way to do even the research even at that time. So Meteor had a lot of hindrances to him, but eventually finally agreed to go on for the research work. And they say the even the Banting, they say used to see a dream. And for that, so what was the dream, which he just summarized in this monograph? The ligate the pancreatic duct of the dog, keep the dog alive till the SNI degenerate, leaving the islets, and then isolate this internal secretion of these and inject into another dog where the duct has been ligated, so who has become a diabetic. This will relieve glycosemia. And this was a plaque which was placed in honor of Banting, who conceived the idea which led to the discovery of insulin in this house. So that house is there in on October 30th, 1920. Next, please. So Banting's era was also not an easy era, and he made a lot of attempts, in fact, to discover the cure. But I think he was persistent in his, and he had a continuous pursuance in his efforts. And you can see that he conceived the idea, then he started working on the dog, same. And one of the dogs became very, very historical in that way. The name was a Marjorie. And then he could find out the pancreatic extract was tested in dogs. And even in that note, there was initially there was an increase in glucose urine because at that time the blood glucose was not measured. So there was an increased possibility that was because the pancreatic extract consists a lot of glucose. So that was responsible, followed by a decline in urinary glucose. Then the James B. Collick, who joined the team and purified. And in 1952, they did a one human tried on this pancreatic extract was tried in a one human being. It failed, in fact. And later on, in January 23rd, 1923, the Leonard J. Thompson, who was the first person to receive and showed a remarkable recovery after the use of insulin. So this was the whole scenario. But I think you can see that the span which the Banting and West took, it was only around 2.5 years. So it was a it is one of the very fastest discovery in that way. And he got the Nobel Prize for that work. So I think that another credit and incredibility the Banting have. Next, please. So these are the fantastic four of insulin discovery. The Banting, Bess was the medical student at the time, and he was chosen by the Banting to work with him. Collick was a biochemist, and MacLeod was the boss at that time. He was basically a physiologist, and in fact, he only helped to not in a scientific way, but he provided the basically infrastructure help to the Banting. And even when the Banting discovered the insulin, even the people see that the MacLeod was basically holidaying in Scotland at the time. So he received the Nobel Prize, and it was a kindness of Banting that even for a patent of insulin, he took only $1. So and that's why, and later on the patent was given to Lilly first, and later on to Nobel. Next, please. Yes. So the most important discovery of 20th century, which has given life to the millions of people over the globe, the Frederick G. Banting was the youngest scientist to receive the Nobel Prize in medicine at the age of 32 years in the year 1923. And another important point was that he had a shortest duration of research work of 3 years prior to discovery of insulin. That's one of the very shortest duration of the research work, which accredited him to have a Nobel Prize on discovery of insulin. Next, please. And this was the first child, Leonard J. Thompson, who received insulin and received around insulin for a period of 3 months and got a 15 pounds weight with such a remarkable anabolic effects or pan-anabolic effects of insulin, which is very well evident in this child. Next, please. So if you talk about a post-Banting era, that was also so many amazing things have been done in that. And this was the first in 1936. We had a NPH, hexagon came. Then we have a recombinant DNA. Then we have so many insulin analogs that came into light, and then they were all long-acting analogs, and then the short-acting analogs. So the whole period was so many discoveries or so many inventions during this period, which we had from spanning from 1923 onwards to 2016. And now we have a armamentarium of so many insulins with us and many availabilities of these insulin to tailor-made to these patients what the patient usually really need for that. Next, please. In addition, even over the past 100 years, we have a plethora of antidiabetic medications. When we had our DM program, we only had a gabapentin and sulfonylurea, and metformin, even it was not there, we had only fenformin at that time. So we have so many discovery of plethora of oral antidiabetic medications. But I think the insulin, next please. There is no substitute to insulin. So insulin is entirely different from all antidiabetic medications, oral antidiabetic medications which we have. Next, please. So salient features of insulin is that the beta cell glucose axis, it matures during intrauterine life. It is around 26 weeks. It is the axis which is the earliest to mature. For all endocrine axes, they start appearing by the 12th week. They start functioning by the 14th to 16th week onwards, but they usually mature after 2 to 3 years after the birth. But insulin glucose axis, in fact, it matures even in an intrauterine period. Otherwise, you have always a risk of a fetal hypoglycemia. Insulin is a pan-anabolic hormone. It has got a beneficial effects on not only on carbohydrate metabolism, but on protein as well as on fat. As opposed to growth hormone, which is considered as the most potent anabolic hormone, is anabolic only for the protein, but it's an anti-insulin and it's an anti-lipids. Insulin, you will be surprised to know that beta cells even is also equipped with the insulin receptors, and insulin is trophic to beta cells. It not only reduces glucotoxicity and lipotoxicity, that's why it improves the beta cell trophic effects, but it de novo also has a trophic effect on beta cells. And it's one of the most potent hypoglycemic hormone, as it stands alone against 4 counter-regulatory hormones. So you see the 4 powerful counter-regulatory hormones and one very powerful single hormone as an insulin. Next, please. Insulin in type 1 diabetes is indispensable, and omission of insulin in type 1 diabetes is suicide. Next, please. The insulin in type 2 diabetes can be used at any stage of disease. It can be used at any spectrum of hemoglobin A1C. Effect of insulin is always consistent and predictable. It can be combined with any OADs and injectable like GLP-1 analogs. It never loses its efficacy with advancing disease and has no limits to reduce hemoglobin A1C, certainly at the cost of higher incidence of hypoglycemia and more weight gain. And newer analogs have made patients' life easier in terms of self-intensification, self-monitoring of blood glucose, and quality of life. So insulin has no substitute. So the discovery which we had in 1923 has got immense impact on the lives of the millions of the people. Next, please. Why we still need a better insulin? We have got so many analogs, so many things, and still there's a vacuum. Still there is space. We need something new. So before we understand that why do we need a better insulin, we must understand the physiology of insulin secretion. There is a 50% of the insulin is secreted in basal state, while the rest is pre-wheel boluses. As a pre-wheel boluses, that's a prandial insulin that contributes almost equally 50-50%. Yeah, the basal insulin is as a part of the rapid oscillatory pulses which occurs at every 8 to 15 minutes. Then there are ultradian pulses which occurs every 80 to 150 minutes. The average insulin secretion per hour is roughly in a normal BMI. Say I will say up to BMI of say 25, it's around 1 unit per hour. It regulates your fasting plasma glucose and intraprandial glucose and suppresses glycogenolysis, lipolysis, and proteolysis. A prandial insulin, which contributes around 50% of the total, first phase happens in 5 to 15 minutes. So even in fact, it happens even before the food reaches to the stomach. So it's basically a cephalic phase. As soon as you see the food, or possibly you might take one bite, that leads to release of first phase of insulin. That's why we are trying to come into near to the first phase. The second phase is around 30 to 90 minutes and regulates postprandial glucose and lipolysis. In type 2 diabetes, we all know the basal secretion is diminished. The first phase is lost, and even the earliest defect, even in type 2 diabetes, is loss of the pulsatile insulin secretion, even prior to the loss of first phase. And second phase is relatively prolonged. Next, please. Yes, so this is just as a mirror image picture of glucose and insulin. You can see that the basal cover, which is by basal glucose and basal insulin. So you're trying to maintain a glucose something around 70, 80 milligrams per deciliter at baseline. And then you have the preprandial pulses of glucose and preprandial pulses of insulin. So exactly, it's a mirror image picture of glucose and insulin, and it's a minute-to-minute glucose regulation, which keeps the glucose and insulin in a very, very tight range. Next, please. Yeah. So approaching a physiological profile even further. So we have got a for prandial insulin. We have a regular insulin. We have a rapid acting insulin. So we are shifting. The curve is shifting to the left, and you can see that we are reaching towards the first phase of insulin secretion, which is truly a cephalic phase of insulin secretion. And next, please. So we have got a even the ultra fast insulin that we talked about. I think Harinaran also Hari also talked about the FIAS. So we are reaching towards the first phase. So the curve is shifting to the left. So we want that very faster onset of action, a higher peak. So the early glycemia can be covered by that, and that peak is lasting for at least 2 to 3 hours. So this does not allow to have a later post-prandial hypoglycemia. So it's a physiological insulin secretion replaces early phase of insulin secretion, more effectively control early PPG, and reduces the risk of late hyperglycemia, and have a better profile for pump therapy. Next, please. Then this early insulin exposure, which we talked about the FIASP, and you can see that even the onset of action is 5 minutes earlier. So you can see that the SPART is around something around at 10 minutes, and while the FIASP is something around at 5 minutes. So it's a 5 minute difference in that. And if you look for an AUC in the first 15 minutes is around fourfold higher, while in first 30 minutes it is twofold higher. So higher AUC, the total AUC is same with SPART and FIAS, but the total AUC which you achieve in the first 30 minutes is faster, and it's a greater appearance of insulin into the first 30 minutes. That's why the area under curve is twofold higher now, and that allows the first 1 hour better glycemic control as opposed to SPART. And this is same reflected, next slide, same reflected in the clamp studies. Next, please. Next, yes. Same reflected in clamp studies. No, previous one. Yes, where we again show that the area under curve is around 48% higher in patients with FIAS as compared to SPART. So the glucose infusion rate is higher with FIAS as compared to SPART. So meaning by that, it's a larger area under curve for insulin in the first 30 minutes. As opposed to SPART and human insulin, you can see that the onset of action somewhere around 25 minutes and much smaller area under curve in first 30 minutes. Next, please. So this is summary of the pharmacokinetics of the all prandial insulin. So this all I think everyone is aware of that. Next, please. Yes, as far as the long-acting insulins, we have got a Tresiba. I think the Gludet has already been talked about that. So we have got many advantages. It's almost a peakless insulin. So we don't have the ups and downs like that one. Its doses are OD. It's a better postprandial control, better fasting control, lower glycemic variability because intra-individual and intra-individual variation in absorption of insulin is minimum. I think the most important insulin which has the minimum variability was Datina, and then the glargine stands in between, and then the diglutide, which is also the least variability in absorption of insulin. Because it's a natural tendency of the insulin molecule to show a variability, and the variability is greatly reduced with these newer insulin analogs. Then we have got a combination of both the Digludec and Aspart that is also available in clinical practice. And we have got now the U300 glargine, which I think serendipitously was found to have a altered pharmacokinetics because it was a concentrated insulin that showed a more prolonged duration of action, and actions are more or less similar to the, as far as concern is similar to the Digludec. So even the nocturnal hypoglycemia have also been shown to be lesser or comparable with Digludec. Next, please. And recently we had a available data for ultra long acting insulin analogs. That was insulin 287, named by as a Icodec by the Novo Nordisk. Again, it has got a peptide backbone which is a proteolytic resistant, and it has got a fatty acid side chain which binds to albumin. That's a very special technology with Novo. Action peaks at 16 hours and action lasts for the T half of 196 hours. And it's a known inferior to glargine in terms of efficacy and probably safety. So see the data of that. Next, please. So if you see the change in a glycated hemoglobin with Icodec versus glargine, hardly any difference from 6.7 to 6.9, so only a difference of 0.2%, which could not, so it's a once week versus daily glargine. And in the number of the people achieving hemoglobin A1C below 7, slightly higher with Icodec as compared to glargine. And even person achieving a target hemoglobin A1C below 6.5 higher. So as you reach near the target, the probability of hypoglycemia increases, but you can overcome by these long-acting analogs because of their peakless effects. That's why the probability of even a nocturnal or a daytime hypoglycemia is much, much less. Next, please. So adverse events with the Icodec as compared to glargine, there are more hypoglycemic alerts with that because once it is absorbed, then you can't take it back. So hypoglycemic alerts were more and it was significant in fact. So there was a odds ratio was 1.84, almost twofold more hypoglycemic alerts. However, the clinically significant or a severe hypoglycemia, it was higher but could not reach a statistical significance, and data for a severe hypoglycemia was pooled here. So alerts were definitely more, but clinically significant or severe hypoglycemia were comparable. Next, please. Yes, we have got some word about oral insulin. The one, even from our own country, the Biocon came even in 2011 on IN 105, and people have tried many carriers. Different carriers have been used, even a B12 extern, lipid nanoparticles, pegylated calcium phosphate. And now in 2020, the Oramed is the one from which we have initiated phase 3 trial of oral insulin by the name of ORMD 0801 in patients with type 2 diabetes. And the data which have been shown but not published, have been shown only on the website, was that there was a better glycemic control both day and night. But certainly, if you use in patients with type 1 diabetes, you always require a basal insulin along with that. You can't rely, oral insulin is just like a prandial insulin. Next, please. Yeah. So a word about Afreeza because it was one of the inhaled insulin. Now it is taken by the CIPLA, and I think some of the centers in India, they are also doing the trial. It's a rapid-acting oral inhaled insulin, recombinant human insulin bound to some carrier particles. absorbed via lung parenchyma. Onset of action is very fast, and the T half is 180 minutes. Single-use cartridges are available at 4 and 8 units, contraindicated in COD, asthma, and smokers. And previously, with the Pfizer vaccine, it was shown that there was an increase in the risk of lung cancer. But the available data with this is that there is no increase in the risk of lung cancer. And you see the comparable data with SPART. Next, please. If you see the comparable data with the SPART, the onset of activity was, the absorption is faster with inhaled insulin or Refriza as compared to this Pro. But if you see the glucose infusion rate in the claim, it is lower with Refriza as compared to SPART. So despite of having a faster absorption, far early appearance of insulin into the blood, but still the action is not faster. So that is the issue with that, that despite of a faster absorption, it is not translating into the early increase in glucose infusion rate, what you see with the S part as compared to Refriza. Next, please. Yeah. A word about a smart insulin. The glucose-dependent insulin formulations are in progress, and the Merck has tried with a smart insulin. They have nicknamed as a 2640. The smart insulin, it's a polymer, in fact, in which it is bound to with a multivalent glucose binding molecule, and insulin is released when these polymer acts in response to higher glucose, say threshold, like a glucose of 140 or 150 milligram per deciliter. The insulin is released from this multivalent glucose binding molecule and this. And same has been translated into next. Yeah. So this is the insulin patch where you have these micro needles, which is studded with so many pores, and there is a one. This consists of a one hypoxia responsive polymer. So whenever the glucose levels rises to a limit, to a threshold, then the glucose oxidase metabolizes it, and this leads to decrease in tension of the hypoxia responsive polymer, which allows its breakdown and the release of insulin molecule. So these are called as insulin patch. They are also in the progress of development, and hope we'll have sometime these patch will be available for clinical use. Next. And so many things, and I'm not covering this, I just covered mainly focus on insulin, so many delivery devices. You have a syringe from pen, injector, insulin pump, and you have your Libra and for monitoring. So many things are now available for that. So the whole technology, in fact, has changed the whole scenario in these patients and have made the life easier for the patients with diabetes. Next, please. Yeah. So to conclude, in the last 100 years, several advances have been made in insulin therapeutics, delivery devices, and monitoring systems. These developments have brought us closer to near physiological delivery at convenience with the aim to achieve Qubix. However, we are still far away from ideal. We are shifting. We want to shift to the left. So we are still looking for the way, and we have to still a lot of work has to be done for the delivery devices and monitoring system. Still, to do a 7 to 8 times peak for daily glucose estimation is still very, very painful. And every people cannot afford the CGMS. So there are issues, so it has to be taken care. And however, the future is pregnant with many possibilities. We will have many things. But these last 100 years have been a very, very remarkable and incredible for the development of diabetes and therapeutic aspects as well as monitoring devices. Thank you. Thank you for your patience here.
Thank you very much, Professor Anil Bhansali. That was a wonderful overview of the story of insulin, starting from before its birth and continuing the saga. And I suppose you have looked at the program and so have not divulged whether the usage of insulin is likely to be overcome by the other newer agents that are coming or will be coming in future. So thank you once again for this wonderful opportunity, for the excellent oration that you delivered. So on behalf of all of us at Diabetic Association of India, West Bengal, on behalf of my co-chairperson, Professor Shalil Pal, Thank you, and we look forward to seeing more of you, hearing more of you, from you, learning more. Thank you very much. So we
Thank you.
close this.
Thank you. Thank you, Shubhankar, for very, very kind words.
Thank you,
And thank
Bhansali
you,
sir.
Anil, for being